Namaste and welcome to all the participants of Easy Ayurveda Gurukula to yet another session, 12th session of Gurukula. Today we have with us Dr. Shivalila Mallapanawar. Madam is Associate Professor and Head of the Department in Department of Shalya Tantra in Sri Kalidas Ayurveda Medical College and Hospital, Badami in Karnataka. Madam has done her UG from Taranath Government Ayurvedic Medical College and Research Center, Ballari, and has completed her post-graduation from NK Jabshetty Ayurveda Medical College and Research Center, Bidar. Madam is a good academician and also clinician and has her surgical practices. She handles many surgical cases, demonstrates them to the students, and also has treated many surgical cases in her clinical practice of over 9 years. So today, Madam will be presenting on the topic Management of Bhagandara, Apamarga Ksharasutra, and Nishadi Taila Poorana.
So today let me discuss about the topic of management of Bhagandara with the Apamarga Ksharasutra and the Nishadi Taila Purana. So in that the first etymology and the definition, as Bhagandara word comprises the two words, that is a Bhaga and Dharana. So Bhaga is nothing but the structures that present around the Guda, including the Yoni and Basti Pradesha. And Dharana, it says that is a tear of a surface will be there, and it is associated with the pain is there, and it is one among the Ashtamahagada. So regarding the definition of Bhagandara, Sushruta Samhita in Nidana Sana 4th chapter, there's a reference that's a Payohasa Dvayangula Deshe Gudamula Sa Rupchwaraha Bhagandara iti Vigneya Pidako Ato Viparyeya. So that is at the area surrounding to the anal verge within the 2 angula Pradesha, deep-seated pathological condition will be there that is associated with the pain and inflammatory symptoms will be there, that is joy and all will be there. Then it is called as an Bhagandara Pitaka, and when it is burst out, it leading to an Bhagandara. And regarding the fistula in fistula in the Latin word, it means that the meaning of reed, pipe like or flute like structure will be there. So this fistula, it is nothing but an abnormal communication between any two epithelial line structures will be there, and it is usually result from an anorectal abscess only, and it is considered as an difficult and recurrent surgical disease. Regarding the definition, the anal fistula is a tract that is lined by an unhealthy granulation. It may be single or the multiple with an external opening in the skin of a perianal region, and an internal opening will be there in the anal canal or the rectum. It's concerned to the epidemiology. So the incidence rate will be there, 86 cases will be there in 1 lakh population, and 70 to 80% of patients requires definitely a surgical intervention. And the ratio between the male and the female is 2.2 is to 1. And the age group is usually the incidence what I have get is, and the cases, number of cases are in between the age group of 25 to 45 years, more incidence will be there. That's why the mean age of the patient is considered as 38.3 years. And the non-specific fistula are 90.4% and specific fistulas are 9.6%. And the 50% of a anorectal abscess definitely in future they are landing into an fistula only. Next in Nidana, that is a causative factor. That is a intake of an asatma and guru ahara, ati vyavaya, vegadharana, and even the improper position, hasta prustayana, that is walking over riding over the animals, and astishalya, and then truna krimi, and even the arshodnidana sthaula, that's a obesity, and even in some conditions like vaidyakrita aparadha, that is an improper insertion of vastiyantra, that may even cause the fistula. And regarding the etiology, it is divided in the two categories, that is a non-specific and the specific. So in the non-specific, the maximum incidence will be there as an because of an cryptoglandular infection. These are the anal crypts are nothing but an proctoreal glands that are situated in between the sphincters, and it has an ducts, those will be opens into the anal mucosa. So because of the infection of that crypts, that may causes an formation of fistula, and even as a sequela of anorectal abscess also causes an fistula, and sometimes previous pyogenic abscess that also causes an fistula. And some specific causative factors like tuberculosis, anal fissure,
ulcerative colitis, Crohn's disease, colloid carcinoma, leukemia, and because of the trauma by the any sharp instruments and sometimes foreign body intrusion, radiation, lymphogranuloma, immunocompromised state, and even in infectious dermatitis, pelvic inflammation, and even who have underwent further surgical in the past, like maybe rectal, obstetrical, or gynecological cases also. And next is an samprapti. So regarding the samprapti, in our classics, the disease has been under the heading of an Shatkriya. So here in the first avastha is nothing but an sanchaya avastha. That is a stage of accumulation. So because of mithya ahara vihara or maybe trauma, there will be accumulation of the doshas will be there at their normal site. And second one is an prakopa avastha, nothing but stage of provocation. So here in this stage, the doshas are get further aggravations and the vata becomes more active than pitta and kapha will be in a passive state. So from here now doshas are ready to move from its own side. And next is prasara avastha, nothing but stage of propagation. So here already the aggravated doshas start to migrate from its own side and circulate into the throughout the body. The fourth avastha is an sthana samshaya, stage of localization. So here the vitiated doshas will settle in there is a reference that is a yatra sangaha kavaikunya vyadis tatropajayate. So that is where there will be susceptibility will be there. So there the doshas will get settled and the disease development will be starts. That's a pathological manifestation will be there. So that's why here or the Buddha Pradesha is considered as a susceptible area. So there the Mamsa Dhatu and Rakta Dhatu, the doshas will get settled and vitiates the dhatus also. And even this is a stage considered as a stage of even the prodromal symptoms appearance. That's why in this stage only the Poorvaroopas will be appears like Katiruja, Kandu, Daha and Shofa will be there. And in the fifth one, that's a Vyakti or Vyakta Avastha, is an stage of manifestation. So in this stage, the Bhagandara Pidakas will be developed, maybe in Apakvavastha or Pakvavastha, and that may leading into formation of either Nadivrana or Bhagandara. And the last is the Bhedavastha, stage of complication. So here, the developed fistula may that is communicate with the adjacent organs that and even sometimes it may forms and multiple tracts also. That's why when this fistula tract will communicate with the surrounding structures, so through there there will be a discharge of the flatus will be there, or feces will be there, or even the urine and the semen will be there. And next is pathogenesis. So here in the modern, the pathogenesis is explained under the four headings, that is stage of infection, stage of burrowing, stage of abscess formation, and the stage of formation of secondary opening. In the first stage, that is stage of infection, so there will be infection of the anal crypts will be there, and later on, and then the sealing of the edematous crypts will be there, and the spread of the infection will be started. That's why in the second stage of burrowing, so here the infection is started to burrow into deeper structures. So that fistula tract may proceed in any direction, maybe in one or more than one direction. So thereby, at what direction it will move, it will form some respective type of the fistula, or else the internal opening will be started to develop. For example, when the infection will be traversed towards a medial side, that's a anal mucosa, that may cause a submucous type, and when it moves to downwards, so that may cause an that is a intersphincteric plane, that is an intersphincteric type of a fistula may form in the future, or else it may be towards the external through the external sphincter or through the internal sphincter. Okay, and even sometimes the infection may traverse to the upwards direction, that is maybe above the levator animuscle or else below the levator animuscle. And the third one is stage of abscess formation. So here, so the abscess will be completely formed, and in this stage the clinical symptoms are started to appear, and the collected abscess will make sense because there is a quotation that where there is a pus, let it be go out. So body itself by the defense mechanism, it tried to come out from the infected area. So first needed to exit from its own side to the exterior. That's why there it will create some primary opening, maybe subcutaneous or submucous or supralevator or infralevator. So that depend on the area where the pus get collected, that will form some respective type of a fistula. And in the fourth stage, so spontaneous rupture of the abscess will be drained, especially over the exterior side, and even sometimes there will be interior also. So that's why the opening will be there. Secondary opening will be there either inside the rectum or external surface of the body. And next is the prodromal symptom. That's a Poorvaroopas. Tesham tu Poorvaroopani katikapala vedana kandurdaha shofascha kudasya bhavanti. Okay, in Sushruta Nidana, 4th chapter, this shloka will be there. So there is a pain is there in the katikapala, that is over the sacroiliac, and even there will be kandu is there, that is a itching over the anal region. Because of the discharge, there will be local irritation will be there, and that will cause an itching, and even the burning sensation also there, and the show for nothing but the inflammation of the anus will be there or surrounding to the anus. So whenever it will be there in abscess state, that is before going to rupture or formation of an tract, so sometimes there will be inflammation. All the 5 clinical features of inflammation you can see, that is rubor, calor, dolor, tumor, and loss of the functionality. And regarding the clinical features, in our classics, Samanya Lakshanas are not explained. Instead, Acharyas has mentioned the individual in the classification related to the individual type, the clinical features are explained. So, in modern, the clinical features we can get there. There will be oil with the fever is there, and maybe with the past history of perineal abscess will be there. So these clinical features are not unique in all the patients. There may be, depending upon the conditions, the clinical presentations will be there. And in few patients, the perianal abscess will be there, that is leading to formation and discharges the sinus. And in few cases, history of a recurrent attacks of a pus will be there, that the accumulation will be there, that is leading to complaining of the pain, heaviness will be there or the perianal region, and followed by discharge of the pus and subsidence of when it is burst out. So there will be discharge takes place, and definitely the subsidence of the pain and the heaviness will be there. And in few types, clinical features like pain in the rectum and the anus, especially in the sitting position and passing the stool. So especially in intrasphincteric as well as submucosal type of the fistula, the last clinical feature will be there. So depending upon the type of the fistula, even there will be the clinical presentations will be there. Next, regarding the classification, so according to doshas, there are the 5 types of the classifications are there as per the Sushrutacharya, whereas in Ashtanga Sangraha and Ashtanga Rudaya, there are 8 types are there. That is, the first one is Shatapunaka Bhagandara, that is Vata Doshic predominant, and Ustagriva Bhagandara, it is an Pittaja Bhagandara, and the Parisravi Bhagandara, it's a Kafaja Bhagandara, Shambhuka Varta Bhagandara is Tridoshaja, Unmargi Bhagandara is an Agantusha type. These 5 are explained by the Sushrutacharya, and 3 more other are explained by Vagbhata, that is Parikshepi Bhagandara, it's Vata Pitta Doshaja, and Riju Bhagandara, Vata Kafaja, and Asho Bhagandara is Kapha, Pittaja, Doshi predominant. And the classification is there. So Sushruta has mentioned that is a Parachina and Avachina. That is blind external and blind internal. It's also under classification depending upon the where there will be primary opening is there. And let me discuss about the individual type. So in that, the first one is Shatapunaka Bhagandara. As I told you, that's the Shatapunaka Bhagandara is a Vata Doshik predominant, and the name itself says that's a Shata and Ponaka. That is, Shata is nothing but actually 100, but it's not like that. Here, there are the multiple openings will be there. Ponaka are nothing but the Pidakas. Here, there are the multiple openings will be there in Shataponaka Bhagandara. That is a cardinal feature. So that's why in image I have shown you that's a Chalini Vat. So it will, where in the filter we are having numerous pores. Likewise, in Shataponaka Bhagandara, there are the multiple opening will be there. As it is a Vata Doshaja and the doshas are Rakta Mamsa, and the site Adhisthana of Vada is within 1 or 2 angul of the Buddha Pradesha. And regarding the characteristic of Pidaka, it will be Arunavarana, and the pain, particular characteristic of the pain will be there. It's like an pricking type, cutting type, or the splitting, maybe beating, or that is a Dharanava, that's a tearing type of the pain will be there. And the characteristic of the discharge is there will be thin, clean, frothy type of the copious and the abundant discharge will be there. And that's its cardinal feature is it's having a multiple opening. And in the complicated cases, so here all the fistulas usually communicates with the surrounding structures, thereby it will communicates with the viscera and that forms an discharge through the tract. There will be feces at the flatus and the urine semen discharge will be there. Second one is Ustragriva. As the name itself says, that's a Ustra is nothing but camel and the Griva is a neck. So the tract or Pidaka, it looks like a neck of the camel, and it is a Pittaja, Dushasa, Rakta and Mamsaja. Even Adhisthana is also same within 2 angula of the Buddha Pradesha, and the characteristic of the Pidakas are Rakta Varna Yukta, and it is elevated like a neck of a camel. So internally also the tract will be extended. That we can consider as that's a high anal fistulas. Okay, that's a high level fistula. And characteristic of the pain will be, it will be there is an chosha, that is a burning chosha daha will be there. That is a burning sensation will be there. So that burning sensation, it's like an dagda by the Agni and Kshara Karma. When we do the Agni Karma and Kshara Karma, so at that moment what type of the burning sensation will be there? No? So that sort of the pain will be there in Pitta Bhagandara. Discharge, there is a warm and the offensive discharge will be there with Raktavarna Yukta is there. And here also it is when get communicated, there will be discharge of feces, fecal matter and semen, and the urine will be there. And next is an Parisravi Bhagandara, that is it is an Kafaja. As name itself says, that is here the discharge is very significance. It is also Kafaja and Rakta Mamsa are the Dushas. Adhisthana is within 2 angula of a Buddha, and Bhagandara Pidakas are Sthira and Shukla. Characteristic of the pain. Instead of the pain, here there will be itching is there and the heaviness will be there. That is Guruta and Kanduta will be there. And characteristic of discharge is there is a Pichila and continuous type of a discharge is there. So other features like that's the this Pidakas are foam indurated, and the boil will be having an opening with a continuous discharge. Here also when get complicated, there is a discharge of flatus, urine and fetus will be there. And next is an Shambhu Kavarta. That is a, so the Shambhu Kavarta is nothing but like an conch of the shell. Okay, so that is spiral type. So here the causative doshas are Tridoshaja and Dushas are Rakta and Mamsa and Adhisthana also within 2 angula. So the characteristic of the Pidaka will be that is possesses all the 3 types whatever we have studied in the individual types. Sometimes maybe Aruna Varna or Rakta Varna or Shukla Varna will be there. And the characteristic of the pain here also it is combined form. Maybe sometimes pricking is there, burning is there, or itching will be there. And regarding the character of the discharge, here there will be Bahuvarana, Srava will be there. And this Shambhukavarta Bhagandara we can correlate with the Harsashu type of the Bhagandara, sorry, fistula. And next is an Unmargi Bhagandara. It is considered as an Agantuja. That is because initially there is no doshik involvement will be there. Instead of that there will be because of trauma. So there of course hemorrhage takes place, and even because of the hemorrhage there will be chances of an accumulation. There's a local inflammation will be there. So pus will be get collected. So thereby production of the creamy, nothing but time there will be bacteria activity will be there, and that will causes an opening. So Acharya has mentioned that is by the eating of the creamies, so the opening will takes place. Here also when it is complicated, there will be discharge of the flatus feces and the urine and semen will be there. Regarding the classification in the modern, there are many types of the classification. So but I have selected only one type, that is a standardized usually. Depending upon the internal opening of the fistula in ano, where it is situated, whether above the dentate line or the below the dentate line. So that decides the type of the fistula. Like it may be when it is opening is below the dentate line, it is called as a low level fistula, and when it is above the dentate line, it is called as a high level fistula. In the image, we can see that is an so in the low level fistula, there will be subcutaneous type will be there, submucous type will be there, intersphincteric type will be there, transsphincteric type will be there, and suprasphincteric type will be there. So in the high level fistula, there will be extrasphincteric or supralevator or maybe transsphincteric and even the pelvirectal type of the fistula or the classification. And next is an examination point of view. So here, so the thing we should observe is what all the points we should keep in our mind while doing the examination. So first of all, the position, preferable positions are lithotomy position, Sims position and knee elbow positions. But the best thing and commonly we use are a lithotomy position. So in the inspection, what we have to see is, and first of all, we should see regarding the how many numbers of the openings are there over the external, that is in the perianal region. And then regarding the sides of a opening where it is situated, whether anterior half or posterior half, and even the clockwise positions, we should decide. And even when there will be discharge is there, then we should see for that whether it is a serous type or purulent or blood mixed discharge is there. And then even the swelling and redness we have to see. And in the palpation, we should observe for an local temperature also. So whenever there will be still in the state of an abscess, like subcutaneous type of the fistulas, initially when there is no opening, we can see the all the inflammatory symptoms I told. So there will be local temperature will be increased, and even the tenderness will be there and fluctuation persist. And when already tract has formed, we have to see even regarding the induration of the tracts. And next is what we have to see in the per rectal examiner are them. First of all, we should assess the sphincteric tone, whether it is a spastic or else it will be like a relaxed sphincter will be there. And even feeling of a dimple when we do the per rectal examination, we should see it for the internal opening. And sometimes we are feeling like feeling of a dogginess, that is the bag filled with the worms, that type of the feeling will be there when in case of subcutaneous abscess and in the intersphincteric abscess. Later on that will form some respective fistulas. And even we have to rule out the any other associated anorectal pathologies also, that is we have to even observe for the hemorrhoids or else fissure will be there or polyps will be there or else is there any CA. Okay, so that also we should observe in the rectal examination. Last but not the least in the examination point, that's on probing. This is a most important thing. So it should be done strictly and very gently. It's decided by with our Goodsall's rule, because when we do the probing, there might be chances of Vaidyakrita Aparadha, that is, we may create a false passage. So to prevent that, we need a Goodsall's rule. So let me discuss about know about the Goodsall's rule. Actually, this Goodsall rule, it is designed for the sake to assess the internal opening of a fistula. For this, the patient should be in lithotomy position, and we have to draw an imaginary transverse inner line that will divide into anterior half and the posterior half, and even an imaginary cycle with a radius of 3.5 centimeter. So then we have to observe for an external opening where it is situated. So when the external opening will be there in the anterior half of the then the tracts will be opens radially directly into the anal mucosa. And we should remember that is when the external opening in the anterior should be within the circle. But when the external opening, even though it is there in the anterior, but beyond the circle, imaginary circle, so then definitely that also forms an third tract and opens in the posterior midline. Wherever there will be external opening is there in the posterior half, so all the tracts will be curved and open into the posterior midline. So this is about the Goodsall rule. So by this only we can assess or predict where the internal opening will be there. And next is an investigations. So the blood related examinations are routine hemogram we have to do, and even go for a blood sugar estimation, and blood, if at all any systemic diseases are there, then definitely even we have to go for a blood urea, creatine, etc. We should go for the surgical purpose. HCV, HIV, and even HbSAg should be mandatory. And radiological examinations, like the basic things I told you, that is the X-ray of a chest to rule out any specific causative factors, for example, the COX and all. And even the main thing is a fistulogram or MRI histogram we have to do. And other miscellaneous examinations, like wherever the discharge will be there and even the recurrent episodes will be there, better the thing is we should send the pus for the culture and sensitivity test. And even when there will be multiple openings are there, better to do the Montex test. And when you suspect any carcinogenic events, so then better to send for the histopathological examination. So the next thing is Bhagandara Chikitsa. So here Acharya has mentioned the principles of the management under the heading of preventive measures and the curative measures. So in the curative measures, that's the medical treatment or surgical treatment, parasurgical treatment, and even the adjuvant measures are explained. So regarding the principles of management, in Charaka Chikitsa 12th chapter, that is a Virechanam cha Ishana Pathanam cha Vishuddha Margasya cha Taila Daha Sat Ksharasutrena Supachitena Chinnasya cha Asya Vranavat Chikitsa. So Charaka Acharya has mentioned the principles like Virechana, that's a purgation treatment, Ishana is a probing, and then the Patana, that is we made to lay down, open down the track, and Marga Vishodhana, the track should be cleansed, and Taila Daha, that is it's also one sort of an Agni Karma. While explaining Agni Karma, Taila Datta is also explained, so that also to be done, or else even the Ksharasutra therapy can also be done, or else Chedana followed by Ranavachikitsa. So these principles are explained by Charakacharya. So we should not select all the principles to the all the patient. It decided by the patient, the disease pathology will be there in which avastha. So that will decides the selection of the principle of treatment. And in Gada Nigraha, there in the Pidaka stage mentioned that there will be Rakta Mokshana should be done by the Jalavkas. And in Sushruta Samhita, the treatment principles are in two aspects. That is when there will be Pidaka stage and when there will be Bhagandara stage. So in the Pidaka stage, in the Shasti Upakramas, so first 11 Upakramas, that is the Ekadasha Upakramas like Apatarpana, that's the lightning therapy, Alepa, ointment application and all, Parisheka, nothing but an irrigation with the oils, or else Kashayas, and even the Abhenga, that is oleation, and the Svedana, so that's a sudation, Vimlapana, nothing but the pressure we have to give with the fingers, and Upanaha, that is the poultice will be prepared with the Shothara, Kandugna, and even the drugs like Vranaropana and Vranashodhana. So that also to be selected and poultice is made and applied. And then the Pachana and Visravana, that's a bloodletting procedure, can also be done, and that is a systemic snehana followed by vomana, that is emesis, or else even the langana can also be done, and even the virechana, that is a purgation. So these principles will be selected in the Pidaka stage, and in the Bhagandara stage, that is already secondary to the Pidaka, we have to go for a probing, and then excision of a track has been explained, followed by application of Shahara, that's the alkalis, or else Agni Karma, that is a cauterization should be done. The thing we should remember, we should see is an actually the application of Ksharasutra is not directly indicated by Sushrutacharya in the context of Bhagandara, whereas Charakacharya has mentioned it by the cross reference from the Nadivrana Chikitsa. There is a reference regarding the application of an Ksharasutra. So through that we will select the this application of a Shara Sutra. So these principles further divided in the categories like that is preventive measure. So in the preventive measure, first of all, we see we go for an Nidana Parivarchan, that is avoidance of all the causative factors that will cause a formation of fistula or else Bhagandara or Bhagandara Pidika initially. And another thing, in the preventive aspect, we should prevent the pidakas to get suppurate and forms the fistula. So that is, so Samprapti Vigatana we have to do in the between only till complete development of the treatment. And this prevention can be done by the two aspects like local therapies or else general therapies. So in the local therapies, like in the principles we have studied, that is Alepa, Parisheka, Vimlapana, Upanaha, Abhyanga, Svedana, Visravana will be done. And the general perspective for the prevention of the pidakas are like Apatarpana, Pachana, Snehana, and Shodhana will be done. And next is an medical treatment. So this medical treatment can be applied only in the pidaka stage either or else after the surgery for the healing purpose or to aid the healing of the fistulous tract. So this medical treatment can be applied. The local like Rana Shodhana, Rana Ropana drugs can be applied or else even the application of Ushna Taila and Nishadi Taila will be done, and even Ushna Avagaha Sveda, that is the Sijjabat what we advise, and systemic like Deepana Pachana drugs will be given, or Mruduvirechana, Stramsana drugs will be given, and Krimigna Shota Haradravas will be given to reduce the inflammation. Next is an surgical measures. So the surgical measures indications are whenever there will be failure of the medical treatment is there, and even in case of an complicated and agantusha types of Bhagandara, these surgical measures are applied. So here also for the Purva Karma, all the Ekadasha Upakramas will be done like Apatarpana, Alepattu, Virechana procedures. And in Pradhana Karma, Sushrutacharya has mentioned that is first of all we should see whether the track will be Parachina or Avachina. That is whether the track is externally blind external or the blind internal. Then vice versa, we should find out the under opening, then the excision of a track has been explained, followed by application of alkalis, that is a Kshara Karma we have to do, or else even the Agni Karma, that is a cauterization Acharya has, Sushrutacharya has mentioned. The next thing is, so in your mind there might be questions, that is, even though Kshara Sutra is considered as a standardized treatment, but still why this combination of the treatment is selected? So for this actually, in my clinical experience, I have seen many cases when we try with an Kshara Sutra therapist, there are the post adverse effects are more. Like there will be burning sensation is there, pain is there, irritation is there, discharge is there, and even in some cases there will be unsatisfactory healing of the track also persisted. So, for this sake, to enhance the faster cutting and healing of the fistulous tract, as well as to provide for the patient as a safe, painless, soothing, economical, and a complete management of Bhagandara by reducing the duration of a treatment also. So, I have planned this study actually because I have got a reference, that is a Tailam Krutam Gatim Apohati Shigrameva. That is, by infiltration of the oil, the track will heal fast. So that's why I planned this study. The next is an preparation of Apamarga Ksharasutra. So mainly there are the two components we use for the preparation of Ksharasutra, that is on the Snuhi Kshira, latex of a Euphorbia nerifolia, and Apamarga Kshara, that is alkali of Acaranthus aspera, and Haridra Churna, powder of the Kurkuma Lavangam. So in the images we can see that there are the hangers are there in the Kshara Sutra cabinet, and there are the two types of the Kshara Sutra, that's a horizontal or the vertical type of the Kshara Sutra cabinet. So here actually the vertical type of the Kshara Sutra cabinet are there, and nowadays there are many modifications we will get like UV cabin and all. So thereby we used to pick up the select the Kshara Sutra cabin. Okay. So here for the preparation of Kshara Sutra, we do the 21 coatings of these three drugs. So initially the Snuhi Kshira will be applied for a 11 coating. For the next successive 7 coatings should be done with the Snuhi Kshira and the Apamarga Kshara. And next 3 coatings will be there with Snuhi Kshira and the Haridra Churna. We should remember is So Snuhi Kshira, as we collect in the early morning before the sunrise, because it is having a short lifespan. There will be immediate disintegration, integration takes place. So there is a solid part will be get separated and water part will be get separated. So that's why in the better to collect in the early morning and even apply for the coating. So that's the main thing. And regarding the pH values of the Kshara Sutra, this Kshara Sutra has a pH value of 9.72 and Apamarga Kshara 9.7 and Snuhi Kshira as it's 5.6 and Haridra Churna is 6.2. So the advantages of this therapy is actually it is a simple, safe and can do it for the PD procedures. And there is a either minimal or no bleeding at all. And of course there will be minimal trauma will be there and no tissue loss will be there. And it's an ambulatory. The thing is it's a cost effect. So there will be even in post-operative period also very narrow and a fine scar will be remain and there is no any operative complications. And even the persons who are suffering with some systemic diseases can also undergo with these procedures without any complications. Regarding the that is a recurrence, very negligible. It's next thing is a Nishadi Taila preparation. So that is I have taken the reference from the Chakradatta. That is Nisha Arka Kshira Sindhogni Pura Ashwaharana Vatsakaihi Siddham Abhinchane Tailam Bhagan Vinashana. So that is as under reference that is I told from the Sushruta Samhita that is the Tailam Krutam Gatim Apohati Shikrameva. So the use of the Taila when we use along with the Kshara Sutra, definitely there will be faster healing will be there. So that's why this combination of the drugs I have selected the Ghatakadravas like and that is Nisha, nothing but an Haridra or Kurkuma Langa and Arthakshira that is latex of the Calotropis gigantica and even the Saindhavalabana, rock salt, Agni, nothing but an that is Chitraka, Plumbago Zelanica, Pura, that is a Kutaja, Holorina antidysentrica and Ashwahanana, that is Gugulu, Comifera Mukul, and even the Karavira. Vatsaka is nothing but Karavira, that is a Nerium indicum. Along with these drugs, all the drugs will be taken each 100 gram and Arkakshira will be of 20 ml. Along with that, the base will be that is a Murchita Tila Taila will be taken for a 2 liters and 8 liters of the water is used and Madhyama Pak of Taila is prepared and then it is used for the clinical purpose. And next is that is a for the treatment purpose what are the preparation we need to prepare. So in this aspect first of all preparation in concern to the patient. Okay. So and in this aspect proper explanation in regard to the procedure will be explained for the patient as well as his or her attenders and then the written consent should be taken without any forget and preparation of the part and cleansing with the enema is a mandatory and even the tetanus toxoid prophylaxis should be given and when we do it under the localized spinal anesthesia better to give an the cellophane sensitivity test. So this is an preparation in concern to the procedure room. That's these are the requirements for the procedures like instruments and even the Taila, Kshara Sutra, or else maybe primary third we are have to or need to prepare. And next is a pre-medication that is immediately after shifting the patient to the procedure room, change it with the OT gown and record the vitals, start an IV line for the maintenance and even you should plan depending upon the what type of the fistula it is there so that on that base we should either go for an either local anesthesia or then the spinal anesthesia will be given and the main procedure so of course the position preferred is an lithotomy position painting and draping will be done and it's cleansed with an antiseptic solutions then the probing and the procedures. So it should be the probing should be gentle and as I told that it should be in accordance with the Goodsall's rule. And in a patients when the fistulogram or MRI fistulogram has not been done, then we have to find out the internal opening of the tract in the intraoperatively. Then after that there is a probing, then we should go for an usually in the clinical practice. I used to use an primary threading for a 1 day, that's a 24 hours for the sake of drainage of the pus. And when the tract length will be there more than the 6 to 7 centimeter, then the partial fistulectomy to be done better, so that by this the fibrous tissue can be excised and even the healing also good. Otherwise, in the post-operative period, patient feels like something hard, like structures will be there over the operated side. That sort of the feeling will be there. So that's why better to do the little bit, at least even in small tract, no need to go for the fistulectomy. And in the tract that's having more than 6 to 7 centimeter, better to do the partial fistulectomy. And even in a cases where there will be recurrent attacks are there in the past history, there is a repeated episodes of rectal abscess are there. So in that cases also, we have to do the partial fistulectomy followed by ligation of the thread. And on day 2, the primary thread will be changed with the Ksharasutra, followed by the infiltration of Nishadi Taila into the tract with the help of feeding tube size ranging from 4 to 6 depending upon the lumen of the tract. That is attached with a syringe is pushed about 0.5 to 2 ml will be pushed out. Then the Nishadi Taila picture will be kept over the wound and the bandaging will be applied. So then regularly the oil infiltration should be compulsory, but the Kshara Sutra will be changed once in a week till cut through of the tract. Next is an advice to the patient. So the regarding the diet, so plenty of fluids will be advised orally, and a lot of the salads or the vegetables are the best thing. That is the fibrous fruits and vegetables will be advised, and avoid the straining, and switch bath should be done twice a day, that is in the lukewarm water, that is containing with the Tripla Kashaya and added with Tripla Kashaya or Panchavalkala Kashaya. And as a Shamanaukshadas, we can also prescribe, may or may not be required if at a patient complaint of still pain is there. So the Gugulu preparations like Saptavimshati or Triphala, Trayodashan Gugulu or Navakarshika Gugulu will be given. And to avoid the straining, so some drugs like the Kumarasava, Drakshasava or Abhiharista will be given. So in the modern, so the treatment principles are nothing but fistulotomy, the most common type where the tract will be laid into open, and a fistulectomy where ectomy refers to the excision. So here the complete tract will be excised, but the thing is there will be recurrence is also there, and the raw surface of the operated area is very wide, and even the for the healing purpose it will take months together, that too more than 2 to 3 months it may take in this few cases. We have seen modern doctors have operated, and even the recurrence is also most common. And for that case also, once again we have inserted the Kshara Sutra. So after this, there is actually no any complaints after the Kshara Sutra therapies. And even the set-on technique and advancement flap procedure can also be done, and lift procedure, that is a ligation of a intersphincteric fistulous tract, can also be done, and that is a laser therapy, that's an endoscopic ablation of the tract will be done with the laser, and even the fibrin glue, or even nowadays there is a bioprosthetic plug insertion is also one therapy is advised, and some injectable drugs like silver nitrate and all will be injected into the tract. So the instead of the curative purpose, so there are the more complications will be there in the fistula in surgeries. So like that, urinary retention will be there, hemorrhage will be there, incontinence will be there, external thrombosed bile masses will be there in future, and even sometimes cellulitis chances are there. Fecal impaction will be there when the lumen of the anal canal is reduced, and recurrent fistula formation is definitely will be there, and or else rectal persistent sinus is also seen, and sometimes rectovaginal fistula formation will be there, or else when we damage the sphincter, chances of and stricture or incontinency will be most common as complications. So this is about the Pathya, that is a Shali rice, Mugdha, and even the Patola, Shigru, Vala, Mulika, Takravarga will be indicated, and even the Tiktavarga Dravas are indicated. Tilataila, Sarshapataila, Ghrita, Vilepi, Jangala Mamsarasa, and even the honey are indicated as a Pathya. And Apatya, like we have to avoid the Iti Vyavaya, Vyayama, Kopa, and ride over the animals like Ashwaprusayana, intake of a Guru Ahara, Madhya, and even the Vegavaroda, Ajirana Asatmyahara, and even we have to avoid the Sahasa Karma. So next, let me move on to the clinical cases. That is, this image shows how we have to do. That is, initially the probing will be done. So as I told, we have to see the external opening and even the number of opening where it is situated. That's also decided. So here, as the opening will be there in the that is 7 o'clock position, and the internal opening we got is in the posterior midline. So in the first image there will be probing is there, and in the second image as the probes has the eyes in its distal part. Okay, so there we have to tie either Ksharasutra or else initially better we can even apply the primary threading for 24 hours. Then we should take out the probe, then tie the knot. Actually, the Paul has gone, so that's the picture is not clear. So here the Nishadi Taila infiltration will be done after the procedure into the tract, and this is a successive change of the Shara Sutra. So here that's the rod and rail method what we call. We will tie the new Shara Sutra thread to the old thread, and will cut out the previous thread, and the knot should be retained with the new thread, and other end will be held by the artery forceps, and it's taken out. So then we should tie the new thread and cut out the old thread. So these are the few clinical cases. These are the older cases actually. So before treatment, during the treatment, and after the treatment, all the cases we have got is a good result without any complications, and there is no one case has complained any recurrence of the fistulas. So this is how, that is in case of when we do the identification of an internal opening of the fistula tract, when the patient has not underwent for the fistulogram or MRI fistulogram. So either by injecting the methylene blue or the combination of hydrogen peroxide and the betadine can also be used. So this is a let me discuss about the case studies. So this is actually case of an 62-year male patient farmer. Actually, 6 centimeter of the tract length is there, and still patient will be there in the treatment. Okay, so in the image we can see before the treatment there's a probing, and after the probing we have done the partial fistulectomy also, and over that area we have applied the Pratisaraniya Kshara. And in the third image, after 1 week, we have changed the Kshara Sutra. And in the second week, so we can see how much of the healing will be there, and even the wound is also very fresh. There is no serous discharge and all will be there. So in this video also we can see that is a infiltration of a Nishadi Taila into the tract with the feeding tube of size ranging from the number 4 or 5 or 6 can be taken. After that is we regularly it will be advised for the patient for infiltration of oil will be advised. So these are the few more other cases we have done. That is here the cutting rate and the healing rate is also faster when we use it in combination. So see, for the 9 centimeter track we have taken 60 days for the complete cut through of the track. Okay, so this is also another case. It's a 30-year male patient driver. He is also. So here also in these both cases actually the tract has extended to the wall of the scrotum, and in the Shravan patient actually the tract not up to the level but it will be there in the perineal region. So here also 36 days will be took for the 5 centimeter tract cut through. And this case also we can see it might be, we didn't find what is the reason for the occurrence of this. See how bilaterally we have got the tract. Actually, these tracts, the things are, these tracts are not communicated with the anal mucosa. Both the openings will be there over the external surface. Or the one is perineal region and another one is at the perianal region. As the tract length is more, that is, a one track is 10 centimeter and another track is of 6 centimeter. So we planned it to do by dividing the track in the with the two threads. so that we can cut down the duration also. If it will be tied the single thread for single track means it will take many months. So that's why in these cases we can see. So in the last image, actually last 1 centimeter of the track remained with all the threads. But after the completion of our cut through, patient has not came but called back and told that is he's completely all right and there is no any complaints at all. The thing is, this is actually subcutaneous type of the fistula. This is also another case that is actually past history of the pulmonary collapse was there, and even patient has irregularly took the ATT. That's why in later on period, once again there will be formation of these multiple openings in the inner or the inner verge will be there. And here, along with the ATT, we tied the thread, and actually here, as the healing was delayed, that's why it took for 75 days to complete cut through of all the track. Actually, here we made to tie the five threads, apply the five threads here by interconnecting with the track. So that Shataponaka type of the Bhagandara we can see are correlated with such kind of the patient. And this is a one case that is it's actually intersphincteric abscess was there. Patient actually come to the hospital and for the complaint of just pain will be there. And when we observe for the external or the perineal region, there is nothing like swelling and all. But when we did the rectal examination, there is a severe tenderness was there, and immediately we posted for the surgery, and we made took the nick between the two sphincter plane, and then opened the abscess cavity and drained the pus completely. So this case also, and then followed by the application of Kshara we had done, and here also without any complications or no any pain and any complaints also, patient cured completely. Under female patient, that is, it's actually case, the fistula tract, it is a transsphincter type of the fistula it is. The thing is, here, the ramification will be there to even the, that is over the external opening of the vagina. There, maybe because of a infection of the Bartholin glands, or because when I asked for the history, so recurrent vaginal pus discharge sometimes will be there, that too with an offensive type was there. But when arrived to the hospital, there will be swelling over the perineal region around 3 to 5 o'clock was there, and it's a tensed swelling, and we drained the pus completely and applied the Ksharasutra also. Here also, this case get completely cured out. So the Ksharasutra therapy actually is an Indian great contribution to the world science, where we will get a challenging for the treatment. Next class, that is a conclusion. As this Bhagandara is considered as a challenging disease for the complete treatment without any complications. So the combined therapy of Ksharasutra and Nishadi Taila Poorana is used, and even I have got the best outcome without any complications throughout my course of a treatment and even in the follow-up also. So here, when I have calculated the unit cutting time, so this actually unit cutting time will be calculated with the formula of UCT, that is total length of the tract before the treatment in centimeter minus the length of a tract remained after the treatment divided by number of days taken for cut through of the tract. So that will gives us the unit cutting time. So here in the combined therapy, when we used, the cutting rate was good. That is, we took for the cut through of 1 centimeter, we took a duration of 5.63 days, or else 0.0184 centimeter will be cut in per day. And when I use Kshara Sutra alone, so there the unit cutting time taken is an 8.52 days took for each centimeter, or else per day there was a cutting of 0.172 centimeter per day it will be taken. That's why I can conclude that whenever we use the Kshara Sutra, especially to prevent the post adverse complications, better to use. If at all available, Nishadi Taila can be used. Actually, in market it's not available. It is our own preparation. Or else even sometimes Anu Taila can also be used, or Chiravala Taila can also be used whenever we use this Ksharasutra Chikitsa for the fistula in name. Thank you so much for giving me opportunity.
Jay Raghuji has posted here. Just thinking about this from the Western side, the patients who come to the practitioners will be either in the early stages or post surgery. I would appreciate your input on how to provide relief. Can you throw some light on this, madam? We can universally look at this question from Jay Raghuji. Like the patients most often. So let us think Ayurvedic physician or the Ayurvedic surgeon itself, like you, either in the early stages or in the post surgery they will be coming. So like early stages is early stages of Pidaka Rupa, you as you mentioned, like a boil may be there in that stage or after the surgery. I would appreciate your input on how to provide relief. So probably the question is related to the early stages. How would you look at early stages and provide relief? And in the post-surgical cases, how would you see for those who are not going to the Ksharasutra table?
So when it will be in earliest case, that is in the stage of the Bhagandara Pidaka, or else even sometimes definitely there will be an abscess will be there. So there we should observe where the situation of the external opening or still it's a sealed, but internally track is existed definitely. So we have to make a opening of that Pidaka, and as per the Goodsall rule, we have to find out the internal opening also. Then we should go for an ligation of a Ksharasutra followed by infiltration of oil. We can do it.
Okay, thank you there, madam. Mr. Kari Ayurveda has a question. So, did the farmer work within the weeks of treatment, or was the recovery there? Number one. So, the case you presented, madam. Did the farmer work within the weeks of treatment, or how many weeks of treatment the relief was there, recovery was there, so that the person can attend the work?
No, sir. Actually, it's an routinely we can go for our work. That's why Ksharasutra is considered as a best treatment. When on the day of when the Ksharasutra has been changed, only on that day patient requires a rest. Otherwise, duly patient can do his routine works without any problem.
On
When
the
we
day
advise the for the
on the day Ksharasutra is done, or on the day Ksharasutra is changed, we need to take caution on
no,
both these days.
no, sir. In sensitive patients, even at each sittings of the change of the Kshara Sutra, we can advise for the rest. Otherwise, when we apply the this pichu of this Nishadi Taila, so there definitely pain is not persisted. But in sensitive cases, we advise the rest even each sitting of the Kshara Sutra change. As I told, when the combined therapy is used for cutting off 1 centimeter of a thread, we need 5.6 days. So thereby we can calculate. For example, when there will be 5 centimeter tack will be there. So 5 days into 5, that's a near about 30 days we take for the complete treatment. And even the recovery also, sometimes the wound will be persistent. So when the cutting rate is fast in few cases, so for that sake, regularly Taila pitch is applied. So that is still complete healing of the wound. So may take 30 to 35 days. Likewise, we have to calculate as per the length of the track.
Okay, thank you, madam. But the patients will be very curious to know after undergoing Ksharasutra or Taila Poorana, they may ask you, madam, how many days it takes for me to go back to the work. So in those cases, what type of assurance would you give even before conducting the procedure?
Yes, regularly, I told you that is on the day of surgery or for the 2 to 3 days at the time of initial first staging, that is sitting surgery. That's when the partial fistulectomy with the Ksharasutra application will be done in the first sitting. At that time only for 2 to 3 days we advise the rest. Otherwise, with the routine work, we advise patient to come for change of the Ksharasutra. And only in
so like what are the challenges? So because Ksharasutra, how easy or how difficult it is for you to introduce Ksharasutra, to explain and convince a patient at the OPD level to take them to the Ksharasutra table, that distance from OPD to Ksharasutra table, how easy is that journey or how difficult is it? We know the results are the best, but how? What is your experience with the patients? What inhibitions or what queries will they have?
No, sir. Actually, when there is a first attack of the fistula tract, there is a anorectal abscess will be there, perianal abscess will be there. Na? At that moment, patient will not at all agree for the surgery or the ligation of the thread. And in few cases, usually repeated attacks, recurrent attacks definitely will be there. So in the initial period, patient even especially remote areas, they used to go for and to visit the local doctors, and frequently they used to take on medications with the doctors. and when the antibiotics and all taken, so it will be resolved. There will be opening of the pidaka will be there and discharge takes place. Once again, patient get relief, like a feeling of lightness will be there and all. But as it's not a single day disease, or else it's not an 1 week, it's already patient will be in a frustration actually whenever suffering with an fistula in, and
Right.
even this disease actually causes an discomfort in his or her routine work. So because of the underweighting, that's a continuous discharge will be there. So that is what actually we have not get any difficulties for the patient to make them, or we have in the context of giving assurance to the patient regarding the treatment and all. Patient has agreed for the surgery and even took the treatment also. I have not got any complications or
Okay.
else any difficulties.
Okay, thank you there, madam. See, this is it looks like a very interesting combo here. How about doing, see, individual therapies like either an Apamarga Ksharasutra? Would you advise that the combo needs to be done for a better healing, or a Ksharasutra will do in this case, or a Taila Poorana will do in this case? Like you take separate cases, like we can do three groups of studies, only Ksharasutra, only
Yes.
Taila Poorana, and combo of both. Which would you, obviously this looks like a good result oriented approach, but what is your take on that? Individual
Yes,
therapies
sir.
also.
Whenever the, for example, in case studies I have shown, when the track length is lengthier, that is when the few cases there is an extension from the scrotal wall to the perianal region. So there we cannot make the tie too much tight. So in that cases, even that is difficult for the oil infiltration also. So in such kind of the cases, we advise only for the Ksharasutra therapy, and in
Mhm.
few cases actually patients are not feeling for the regular infiltration. The thing is we need to infiltrate the oil regularly. So when the attender of the patient are agreed for the procedure, because it's not possible to come to daily to the hospital because it's a months to get the time taken for the treatment, complete treatment. So in such kind of the cases, we have advised or we have done only Ksharasutra therapies.
Okay, thank you there, madam. And are there any limitations of use of this oil, like in some conditions, like we consider some amavastha or something when there are secretions or exudations? So in such conditions, we should not use. So there are so many rules of using Taila in Ayurveda. So do you suggest any limitations, or what's your
Yes, sir.
suggestion on this? Yeah.
That's why, sir, when we do the surgery, sir, in the day first, we apply only the primary threading without any Kshara Sutra, so that it
Mhm.
will act as a drain. Or else,
Mhm.
whenever there will be abundant discharge is there, we make it for the 2 days. Let it be there, the primary threading only, so that there will be complete drainage of the pus will be there. And once the tract is drained out completely, the abscess cavity, then we will change with the Kshara Sutra, and along with that oil will be infiltrated.
So this is a stepwise approach what surgeons or the Shalya
Yes, yes,
Chikitsak should remember and go in that chronological order. So first drain
yes,
and then do the Kshara Sutra and
yes,
then
sir.
go with the Tailapurana. Okay, thank you, Dharmino.
That will be
And
best.
that will be the best. Okay, so a couple of questions just to finish. Can we get to see there is a big classification of Bhagandara explained in Ayurveda. So, as per classical explanation, do we get to see all types of Bhagandara in clinical practice? What's your
Yes, sir.
experience?
Yes, sir. In Asho Bhagandara also we have seen a cases, sir. And even as I've shown, that's Shambhu Kavarta, and that is of Shatapunaka Bhagandara cases also we have seen, when there will be multiple opening, like persisting with an water can perineum like appearance, and even Ushtagriva, nothing but we can compare it with the high level fistulas,
Hmm.
and Parisravi Bhagandara, where there will be abscess will be there. That's a ischiorectal abscess followed by with an transpynctic fistula will be there. So even such kind of the cases also we have seen, and another one is, and that is a Hashu type, that's a Shambhu Kavarta. So that also we have seen, as I have explained for the female patient. Okay, Hashu type of the fistula tract was there. So these are the cases we have got, and even the Arsho Bhagandar also. That's from the base of the pile mass also we have got an fistula tract, maybe because of the secondary to the fissure bed inflammation. So that has caused the fistula tract, sir. So these cases we have got, sir.
Thank you, Dharmino. for all those students who have some small inhibitions, whether to take up a career in Shalya or not, what are your
Definitely, sir.
tips? What are your tips?
No, sir, definitely. The first thing is we should have an courage. We should not have any fear about to handle the cases. Of course, when we will do with work with a soulful, definitely we will get a good result. If possible, we can try. And even first of all, we should explain regarding the procedures, do's and don'ts, and what all the complications of procedures, if at all we have done in these cases. Such kind of, in all the cases, we should explain for the patient. Then with the willing of the patient, we can do the, especially in anorectal cases, actually Ayurvedic field has a good results, and even there is a, we will get a good success also without any problem, and with the best courage we should handle the all the surgical cases. And even at our
Courage.
hospital, even the modern surgeries also we are going to do with the anesthetist support and all.
Courage is the big key for success in surgery. Rightly said,
Yes.
madam. Thank you. So, on behalf of Easy Ayurveda team, Easy Ayurveda, and all our participants, a big thank you and namaste to Dr. Shivlila, madam, for presenting a very interesting and a very important topic here with the clinical experience and clinical demonstration.
Thank you so much.
It is goodbye. Do take care and loads of love from Easy Ayurveda. Namaste.